Hi, and welcome to Ones and Tooze, FP's economics podcast. Every week we take a couple data points, use them to try to explain the world. I'm Cameron Abadi, FP's deputy editor, with you in Berlin, Germany. As always, Adam Tooze, FP's economics columnist and Columbia University professor, is with us in New York. Hi, Adam.
Hi, Cam.
So this is a special episode in some ways. We'll be taking a break in the coming weeks, at least with sort of contemporaneous episodes. That's because Adam is scheduled to have surgery next week, and he'll be recovering in New York for a few weeks, but then we'll be back responding to the news in January. In the meantime, there will be a mini-series that we've pre-recorded on heterodox economists. You guys can expect that in the weeks ahead, but with this week's episode, we wanted to talk about Adam's surgery from our unique angle that we try to take on this show. And appropriately enough, Adam this week took responsibility for the data point. All he told me is that it's the number 5, and now I'm obliged to ask him, Adam, what is the number 5?
5 as in 5 centimeters, which is the size of the aneurysm on my ascending aorta. That's why I'm going in for surgery. And the more I thought about it, the more I realized, and this is no doubt an effort to kind of rationalize my fear and panic at the impending massive trauma that my body's going to suffer, that this is really rather a remarkable kind of, demonstration of the sorts of things we are, as you say, super interested in the show, and economics and technology and politics to a degree, and also their global ramifications. So if you are fortunate enough, like me, to be in a system with dense networks of heart scanning and monitoring, you have a chance that your aneurysm will be picked up. Aneurysm being an expansion of the aorta that takes the blood out of the heart, and it's a life-saving discovery, and it has a history which goes back to the history of various types of medical scanning. Ultrasound was the original, came out essentially, I imagine, out of kind of radar work in World War II would be my guess. It's pioneered in the US and Sweden and Scotland from the 40s and 50s onwards, because people have known about aneurysms, the threat of a rupture of your blood supply, for as long as there's been medicine. But the terrifying thing about them was that you couldn't detect them until it was too late, or patients would suffer from prolonged periods of pain. And then all of a sudden, the blood vessels would rupture, and then you would bleed out very, very quickly. And 5 centimeters gives you an idea of how wide this thing is. That's 2 inches. So once that dissects, you lose blood at a terrifying rate. But from the 40s and 50s onwards, they began to be able to scan for these using ultrasound and then computed tomography, CT scans, and then began also to develop pioneering techniques of surgery for dealing with it, which started with the type of procedure I have to have, which is the classic, truly the kind of classic cardiac surgery. So they break your ribs, and then they cut out the bad tube and replace the tube with a new tube. And then they sew your existing valve into the tube, the artificial tube. Meanwhile, they keep you alive, because obviously they're literally taking you apart. At your heart, you're literally just, cutting into the blood supply for your whole body. They keep you alive with an artificial life support system. Then you spend a chunk of time in ICU recovering. And the miracle is that from the 1950s onwards, we began to develop the apparatus, the giant hospital apparatus necessary to support this extraordinarily dramatic intervention in the human body. They go literally to the heart of your entire system and cut it open and replace the tube that supplies blood to your entire system, including your brain. Since the 1990s, there's been a big innovation with endovascular aneurysm repair, which involves this remarkable process of basically sort of squeezing a expanding stent by way of a catheter into the artery, and then that expands around the site of the aneurysm and stabilizes the aneurysm. But mine is not of the type that you can do that to, even though those increasingly dominate. It's on the one hand like a classic intervention of modern medicine. It's kind of definitional, really, of cardiac surgery from the 50s onwards. It's where much of the sort of glamour surgery of the 50s and 60s was done. Now the trend really is towards the endovascular aneurysm repair, which is less invasive. There's an interesting difference in the cost structure, as far as I'm able to establish anyway. The big difference is that the procedure I'm having is more labor intensive. It requires hours, I think 5 around about 5 hours of surgery with a super highly qualified team and all of the apparatus of a modern surgical setup, and then, a day, broadly speaking, in ICU if all things go well. Whereas the endovascular approach is more capital intensive in that the stent they put in is this super sophisticated medical device, which costs tens of thousands of dollars. So there seems to be a difference between the two procedures in those terms. Overall, this is a procedure that in the American system costs, on the low end of the endovascular aneurysm, $20,000 up to $50,000 plus for some really hardcore invasive stuff. So basically they're going to be spending the equivalent of a small family car fixing my heart. Compared to my lifetime income expectation from now, that's, if you kind of think in crude economic terms, that's a very worthwhile investment. Globally speaking, almost all modern medical systems do this kind of procedure, as invasive and dramatic as it is. And as high as the costs are in many other countries, the costs fall lower. You can have this procedure done in Asia, in great hospitals in India or in China for closer to $10,000. But wherever you do it, it's high tech stuff. I mean, as a kind of mode of production, I was trying to think this morning about like what it's like, because it's so tailor made. On the one hand, it's a standard procedure. My team do about 200 a year. So they're very busy. I think they do 2 a day on their surgery days, something like that. So it's a routine on the one hand, and yet it's highly tailored to my specific anatomy. And they did countless scans so as to figure out the shape of they're not going in blind. They have a very good idea of what they're going to see, I hope, when they crack me open. Very different from the situation in the 50s where they did exploratory surgery on the chest to discover whether there was an aneurysm or not, like really dramatic interventions like that. That's how they found Einstein's aneurysm in the late 40s. So it's kind of like a high-tech but customized chain of production, and they do in the US tens of thousands of these a year across the whole country. So it's a kind of boutique, tailored, personalized, but on the other hand, standardized intervention. And just to say, and I should maybe have said this up front, I wouldn't be talking about it in this relatively calm terms unless the mortality was now remarkably low. And the risk of not having the surgery done is very substantial. They go in at 5 centimeters because once the aneurysm dilates to 5.5, so 5.5 centimeters, the risk isn't that of an immediate dissection, but the risk is dramatically, steeply increasing as the aneurysm increases in size. I've seen it on the scans, and it's a little bit like looking at a balloon that's that's developing deformations as a result of excessive pressure. And, it doesn't take a heart surgeon to say, hey, that doesn't look very good. Is there something we can do about that bulge? Because the walls get thinner and then it progressively deteriorates.
So that price tag you mentioned in that ballpark, up to $50,000. I mean, do you have a sense of how that breaks down? Where does that money go? Is it primarily labor, or where in this case is it going?
The biggest single item for my type, which is surgery intensive, is in the labor. Whereas with the endovascular, it's actually in the stent, which is this high-tech kind of, it's like one of those sort of experimental balloons that expands inside your body. In my case, I think it's overwhelmingly the surgery.
And so if I understand correctly, they will be introducing an artificial material into your body. I mean, at the conclusion of the surgery, your part of your aorta or will be replaced by some synthetic material. Guess I'm wondering, where does that material come from, and what kind of industry is involved in building synthetic materials for the body like this?
Yeah, they started like more in the vein of sort of transplant by experimenting in the 50s with arteries from cadavers. But in the end, the answer is the modern petrochemical industry. So the most astonishing story is the Albert Einstein story, because he had been suffering from serious chest pain for many years before they decided to open him up and see what was going on. And they found an aneurysm, an abdominal aortic aneurysm, which is, I think, more complicated surgically than the one that I have, because I think there are risks to the spinal cord. You know what they did? This was in 1949. They wrapped it in cellophane. The cling film that we use for preserving stuff in kitchens.
That was the treatment?
The treatment of Einstein's aneurysm was to wrap it with cellophane. And it held for 6 years. He eventually died of a dissection, stoically accepting the fact that he just didn't want to have another round of surgery. And he thought, at the age of 76, his time was done, and he'd had obviously an extraordinary life. but it's in the 50s really that they begin to experiment. And surgeons are, the key thing that surgeons realize is that blood vessels are crazy things. They grow into non-organic fabrics which are introduced into the body. So the thing you're inserting essentially acquires the coating of your normal artery. It's absolutely extraordinary. And they experimented with different materials, and it was really like a home-brewed thing. Like surgeons, the most famous surgeon, DeBakey, describes, I went to a department store in Houston to get some nylon. They said they didn't have any, but they had a new fabric called Dacron. So he went home and on his mother's sewing machine, he created an arterial patch and then took that in and sewed it into somebody. I mean, that's how this got going, is people basically experimenting with flexible new synthetic fabrics. Nylon, it turned out, actually our body has the capacity to essentially, I don't know the biochemistry here, but digest, essentially dissolve nylon. So it doesn't stand up, but this thing called Dacron does much better. And then DeBakey worked with a Philadelphia textile engineer to create machines, knitting machines, essentially, that were capable of making seamless Dacron grafts. This is from the mid-50s onwards. Then they made elasticized woven Dacron grafts. So it's essentially become a boutique, high-end, synthetic fabric business. And then Gore gets involved, the guy who's, I guess, Gore-Tex is named after, who made an expanded Teflon, it's called, which is an exceptionally biostable material, which was the next big advance that began to be experimented with in 1969. And they've been modifying this ever since and tinkering with it. But my surgeon showed me it, and it's like a floppy hosepipe. And it's 5 centimeters wide. I mean, even the normal aorta is 4.5. Like, so this is a chunky piece of tubing they're inserting into me. It's not some slim thing. It's 4.5 centimeters. That's like the best part of 2 inches across. And it's a stretch of it. Like they're putting in like a stretch.
And it will be absorbed into your body.
Well, the body kind of grows around it. Yeah. As best I understand it is in the same way as like when your body heals after a wound, because there's also going to be this wound in my chest. Obviously the body grows back over, and apparently it will grow over a little bit like, I guess my image, and this is just total amateur hour now, it's like, sometimes if a fence or something is drawn too tightly around a tree, the tree's bark will grow around the fence and incorporate the wire. For some reason, I've got an image of like barbed wire being grown into the tree. And I to an extent, I think that's what happens with these grafts they're putting in.
So I'm picturing when you come back, you'll essentially be some kind of cyborg.
Yeah, that's right. Yeah, on a good day, that's what I tell myself too. Certainly improved. I mean, this is the crucial thing here, is like whatever they put in is better than the increasingly baggy and worn out natural bit of my body.
Okay, we're going to take a quick break here right now, but we will be back to continue talking about Adam's heart surgery and the U.S. healthcare system more generally. Maybe we could zoom out a bit to think about the broader healthcare system your surgery is part of. The U.S. healthcare system is kind of notorious for spending more than any other healthcare system in the world. Yeah, I mean, like, what accounts for this? I mean, it seems bloated, but yeah, is it in fact? And what accounts for that bloat?
Yeah, it's funny the way that, I mean, obviously I'm trying my best here to kind of frame what's about to be done to me, or what I've chosen to have done to me, because it's very important to say, purely elective surgery. I can choose to live with this aneurysm and take my risks, but I have the privilege of this choice. And it does rather alter one's perspective on the, as you say, abiding topic of US healthcare bloat. I have to say it's not top of my stack going into this surgery. It's like, spend whatever it takes. But yeah, I mean, the tragedy is that the US spends, roughly, well, not quite twice what most other advanced economies spend. And the reason why we know this is excessive is that it yields very mediocre health outcomes, except for a few high-end, strands of cancer, for instance, where the US does have good results globally speaking. If you look at all the basic indicators of well-being and healthcare provision, life expectancy, infant mortality, maternal mortality is really shocking, the numbers for the US. I did a chart book about this, so one can argue the statistics up and down, but whichever way you end up, even the most revised set of numbers makes the United States look much more dangerous for mothers than any other advanced economy. Yeah, it doesn't produce. So there's this outside spending, 17, 18% of GDP, and it produces mediocre results, I think, in terms of overall rankings. The US is like 40th or 50th in the global rankings of life expectancy and overall medical outcomes, which is catastrophic given the amount of spending. Where does all the money go? I mean, it goes in three tiers, really, I think. The general idea is one is administration. And anyone who's encountered the US healthcare system will know it is just a bizarre, labyrinthine insanity. It truly is. It's amazing. And there's entire categories of professions, very hardworking, serious, often, really you thank the stars for these people whose job it is simply to handle insurance forms, insurance, applications, this kind of thing. Entire layers of people whose job it is simply to untangle the mess that the system is in, because it is a disaggregated system with a variety of private insurers and some public insurers and an absolute plethora of tens of thousands of more or less privatized providers of healthcare services. So it's the antithesis of, say, the British National Health System, which is centrally funded and for all its many faults is nevertheless light on administration, relatively speaking, though people in the NHS constantly complain about it, and with good reason. So that's one element, and we think there the bloat is in the order of a factor or 2 or 3 compared to other countries. How much of the difference that explains depends on what levels of administration you count. If you counted at every single level, we're talking about a big wedge between the United States and the rest of the world. One of the reasons why we think that labyrinthine system persists is it confers market power on players in the system. So it's as messed up as it is because the underlying political economy of the US healthcare system is one that is rigged towards providing pharmaceuticals companies, which basically finance their entire global research programs out of their sales into the bloated American healthcare system. It allows hospitals to charge heavy premium for the services they deliver. And not nurses, but doctors, senior doctors, obtain salaries in the US which are incomparably larger than anywhere else in the advanced economy world. And at each stage, if you like, there are people with market power, and that market power is itself in part protected or expressed in and then compounds the labyrinthine bureaucratic procedures. And the third element, which is the element which I have benefited from, is the what's called overtreating and the use of very, very large amounts and very expensive diagnostic kit. So I know about this aneurysm and I'm having this life-extending surgery because I fainted for an entirely different reason, a vagovasal incident. I have a tendency to this kind of sudden shutdown. And because it was New Haven and, the emergency services there during the day don't have much to do, they mobilized the entire New Haven hospital system to attend to this professor who just fainted during a lecture. And they ran all the tests on my heart that I'd never previously had done, and they established that the thing which had caused me to faint is basically benign. But I'll never forget the moment when I was speaking to the cardiologist. He pointed at the aneurysm and said, "This will kill you, and you need to take this seriously, and you need to understand how serious this is." And it was really one of those, whoa, my life just turned in a direction I was not expecting moments. And anyone who's out there, and I'm saying this especially to the dudes out there, because this is really a male pattern issue above all. If you have yourself scanned in your middle age to see whether you can't find an aneurysm, just have a checkup to make sure that you're not in the danger zone. Because otherwise you're really carrying, if you don't know about it, you're carrying an explosive charge in your chest, which can go off and you will die within minutes, unless you're lucky. And so since then, what they've done is they put me on this regular scanning system, and every time they do it, they mobilize these huge, complicated machines. And we've been waiting for the moment at which the surgery becomes, a better risk to do the surgery than to wait. And you can't do that unless you have huge diagnostic capacity and a willingness to apply this kind of wait and see procedure where you hold an entire system in abeyance until the moment when you pass the 5 centimeter mark, and then it seems necessary to go in. So that creates cost. It doesn't, unfortunately, generate wonderful comprehensive outcomes. And this is, I think, the really further sad thing to add about the American system is that though it spends so much money, unsurprisingly, given that this is the United States, a society so severely marked by inequality, that spending is hugely unequally distributed. So part of the reason why the huge spend doesn't generate fabulous average outcomes is that there is a substantial minority of Americans in the United States, this supremely rich country with these giant facilities, who will never benefit from the kind of care that I'm benefiting from. Their aneurysms will not be detected and they will simply fall down dead, bleeding out, because they were not insured at critical moments. No one bothered to run all the tests on them that they ran on me because I was this, high profile Yale professor in the Yale hospital system. And I'm not saying that the Yale hospital system is biased or sociologically biased, but every health system we know in the world carries social inequality even into the care system. And I, of course, have subsequently been on successive rounds of more and more blood pressure medication to try and control my blood pressure, which is one of the forces of this. So in all of these ways, the American system at the one end produces extreme high performance, the sort of team that I have the privilege of being operated on. And at the other end, just systematic mass neglect of tens of millions of our fellow citizens.
It's sort of eerie to have this conversation with the soundtrack of ambulance sirens in the background. But I guess to look at hospitals themselves as institutions in the United States, I mean, obviously the healthcare system as a whole has a special role in the U.S. economy, but hospitals themselves have special roles in local economies in terms of, anchoring communities. And I would guess in terms of the jobs they provide. So what role do hospitals play in local economies in the United States?
Yeah, they're key. They're what's now known in regional economics as anchor institutions. We did a show a couple of months back about universities as a key feature of this in the US, but hospitals are massive. I mean, if you go up to Harlem 125th, you'll see, the massive campus of the New York Presbyterian Hospital where I'm being treated. And that has a west side Harlem campus and a east side. The Weill Cornell branch is over on the east side as part of the gigantic network of hospitals there. I mean, these are vast operations. You can find out the economics of them because they are businesses and they issue bonds, and so the rating agencies do reports on them, which are really quick summaries of how they operate as businesses. So New York Presbyterian has about 6,500 doctors, 20,000 staff altogether, 2,600 beds. It's one of the largest hospitals in the world. They treat 300,000 plus patients in emergency, deliver 15,000 babies. So they're like a huge footprint in New York. You can break it down. So their revenue, their turnover is 10.7 billion. And of that, they pay to other suppliers, so people who are in the supply chain, who do the swabs and the pharmacy and all of that, 3.2 billion. So that goes out into the rest of the US economy and the global health economy. In terms of value added within the hospital itself, the two key components are wages and salaries. And Columbia New York Presbyterian pays $4.8 billion a year in salaries to its staff. So that's a big slice of the New York economy. 40% of them are covered by collective bargaining. So this is good, unionized, highly skilled, but it's essentially manual labor, but of a highly sophisticated kind, right? So these are jobs. The vast majority of the staff in the hospital will have college degrees, but they will acquire those college degrees from a variety of different ways. So they are also vehicles, I think, of social mobility. If you look at the hospital staff, it is spectacularly cosmopolitan. It's absolutely unbelievable how cosmopolitan the campus is. So out of your 10.7 billion in turnover in 2022, you're paying 3.2 billion to other businesses that are supplying you with stuff. You're paying your workers 4.8 billion, and then you're generating in profit. And this is not a principally profit-orientated business. You're generating about 450 million in profits, operating surplus. So altogether, I figure the value added of New York Presbyterian Hospital is about 5.5 billion. That's what would go into the national accounts. And then you can scale this up, right? So in the New York, Newark, New Jersey City conurbation, there's 20 million people living in this sprawling complex. There are 428,000 hospital employees. So New York Presbyterian is a big slice of that. It's 5% of all of the hospital workers in that complex. Across the United States, 330 million people in the country, 6.3 million people working in hospitals. So 2% of the the entire population working in hospitals. The total workforce of the US is 160, 170 million. So 6 million workers is a very big deal. I would guess that hospitals, if you ratioed up the New York Presbyterian value added per worker, you would end up with hospitals alone, not the healthcare system, insurance, all of that apparatus, but hospitals as value added generated centers, maybe $1.5 trillion in a, $22 trillion economy. So like a big slice of the US economy is being generated in the wages and profits being earned in these hugely high-tech. I'm trying to I'm very fascinated by this now. Like it's an artisanal mode of production. Like they go in and they will cut away at my heart. In this team, they will do 200 people every year with $40,000 to $50,000 per case and contribute to this flow of income. It's actually a really fascinating way of looking at the, coin a pun, like the anatomy of the US economy.
Yeah, and there's no remote way to do this.
No, it's hands-on. Yeah,
exactly.
It's really tactile. It's craft work. I mean, that's the joy of speaking to the team, and the really reassuring thing about this team is like they're going to feel really bad if they screw up. It's the thing you really want to know is like they are seriously invested in not screwing this up. So they're like, well, what is it? Somewhere between engineering and craft skill and artistry and butchery. Like, it's somewhere, sushi chef, like something like that. Like, super high end. Super high end.
I don't imagine the person at that crossroads, sushi chef or heart surgeon. I don't know. People find themselves at that fork in the road. But
imagine that piece of tuna, that priceless piece of tuna, and you have it in front of you, and you have to make the first incision. Like it's that kind of, of moment. Yeah.
What are we all but
slabs of meat,
but slabs of tuna on at the end of the day. But to return to the, I guess, anatomical questions that we were talking about before. I mean, the heart. Obviously, you're undergoing heart surgery. I mean, heart disease in general is a global phenomenon. Heart attacks happen everywhere in the world. I mean, what sort of global public health risk does heart disease pose? And what are the kind of economics involved in that?
It's a big deal. So abdominal aortic aneurysm worldwide is thought to affect 1% of people walking around between the ages of 30 and 79. So in any room of 100 people, there's one person with my condition. That translates to millions and millions of people worldwide, obviously, huge numbers. It's closely linked to smoking, to male sex, to a family history of AAA. So it turns out that my paternal grandfather died of a dissection. And that wasn't something I'd really figured into my biography until I got the diagnosis. It's linked to age, and so as global society becomes older, we're going to have more and more of these. It's linked to hypertension, obesity, cardio. It's a classic disease of rich societies, and it affects literally millions of people worldwide. And the thing about it is, if it's untreated and you get to the dissection, the global fatality rate is 81%. And a third of those generally die before getting to hospital. So if this is untreated, it's extremely dangerous. And even after treatment, if you get to the point of dissection, your survival chances are much, much reduced. They're really quite bad. So globally, the number of dissection deaths has increased from 95,000 in 1990 to 172,000 worldwide. That's in societies that count, mortality statistics at the level which would allow us to make that kind of statement. So it's an increasingly important risk. And that's not surprising because global society is growing older, and that's the main driver of this, right? This is one of the things, when we say somebody dies of old age, this is one of the things they die of with old age. The risk of this killing you just increases enormously. But for any given group of people, what's happening is the death rate is progressively falling over that same period. So the age standardized death rate fell between 1990 and 2019 by a third, even as the overall number of people dying massively increased, because we've gotten much better at detection, we've got much better at treating hypertension. But this is it's a disease that affects literally everyone on the planet. African people have aneurysms too. This is the crucial vital thing to say. But it's in rich societies where we live long enough to really fully live out all of the risks of old age that this is becoming an absolutely dominant form of death. And why also then the effort around early detection. Again, to all listeners, go have yourself scanned. Early detection and sophisticated treatment is possible.
Yeah, I will ask my doctor.
Yeah. No, you should just have a scan to see whether everything looks all right. And if it does, then there's probably no reason to go on worrying about it, because you don't have too many bad habits, Cam. None that I know of anyway. But people should get themselves checked out.
Yeah, I'll have to translate aorta into German. I don't know how to say that. But I guess to return to something you mentioned before, I mean, the global inequalities in healthcare access generally. I mean, just to clarify, I mean, do you think you would be getting this surgery elsewhere in the world? I mean, if you were living elsewhere, I mean, how do you think that would look?
Yeah, so it's really fascinating looking at the history of cardiac surgery in the advanced economy world, rich countries, in other words, to use a less kind of evaluative term. Cardiac surgery is a kind of collective achievement. The first heart transplant was done in South Africa. The endovascular work was done in Argentina and the Soviet Union. The early use of scanning technologies was done in Europe and the United States after World War II. So across the advanced economy world, I think it's almost like it's just one of the frontiers. It's a little bit like brain surgery. It's one of the frontiers of medicine. And so doctors around the world have vied with each other, competed, imitated, proudly learned the skills of a profession that is global to that extent. And the largest treatment centers, the places doing the largest volume of the kind of surgery I'm having, are not in the West, but in China and India, predictably, where the overall provision is lower than in the West, but there's extremely sophisticated surgical and medical training and vast volume. And for success in this surgery, volume's the key, right? You learn by doing. And the most risky place to have this kind of operation done is in a place which doesn't do much of them. So you want to be in the place where there are teams doing it every day, because that's how you get good at it. You learn all of the tiny, tiny warning. This is why I think it has elements about it of a craft in the best possible sense, right? A whole bunch of embodied knowledge that can't, strictly speaking, be formalized, but has to be learned. Literally, the phrase they use is hands on the heart. Like, who gets to put hands on the heart is the central thing. And in the places where you have the best outcomes, you have only the most qualified surgeons with their hands on the heart. The assistants do the opening up and the closing, but they don't do the main operation. So across the world, there is cardiac surgery. There's 1.5 million procedures done every year, but it is also one of the areas, because it's so expensive and so sophisticated and requires the collaboration of so many people in a team, where the inequalities are just absolutely crass. There are maybe 5,000 or 6,000 centers across the world that can do cardiac surgery. And there are, I believe, 90 in all of sub-Saharan Africa with a population of 1 billion people. So there's something in our minds that when we think medical provision in Africa, we think hydration, diarrhea, malaria. We don't even, there's something, it's almost like a cognitive disconnect where we think, well, why would heart surgery be relevant? Well, because they have large populations of people with human hearts, and you have aneurysms, and virtually none of them get treated. And so millions of people every year die. 18 million people, according to some estimates, die every year of surgically treatable conditions, which are just not recognized, just not captured, and just get registered as a heart attack rather than being subject to the minute assessment. They tracked the expansion of my aorta by the millimeter over 10 years. The scan is adjusted to the beat of the heart, so that as the pressure of the blood builds up, they capture the picture at the precisely right moment. I mean, that, at one end of the scale, and at the other end of the scale, literally billions of people who have just no access to this at all. And it's become a political issue within the surgical profession. It's really remarkable. I'd honestly not thought about this till you asked the question. But for the last 25 years, there has been profound soul searching within the US medical profession, led by James Cox, who gave an address at the American Association of Thoracic Surgery in 2001, which is one of the great moments of global health, right? It's during the AIDS pandemic. It's when global vaccinations get going. And the surgeons also begin to ask themselves, how can it be that, having taken the Hippocratic Oath and developing these literally miraculous godlike skills to open people up, cut their components of the heart, put them back together again, we essentially confine this to a tiny fraction of the world's population. And so there was a Cape Town Declaration on Access to Cardiac Surgery in the Developing World that came out several years later, which is trying to pose this question, because it was Christian Barnard in Cape Town in South Africa who actually did the first heart transplant. So there's a sense in which South Africa belongs as part of the storied history of heart surgery, and yet where is South Africa now in terms of the access that can be provided to the majority of population? And so there's quite a serious, amongst those who are globally minded in this field, I think, soul searching about just this vast disparity that manifests itself so much more clearly here than in other areas. And the most optimistic view is that you really have got to move past the mission-centered. So once upon a time, you'd have these stories of Western heart surgeons, flying into emergency areas and doing operations on, charismatic individual patients. And the idea now is that the way to go is actually to use cardiac surgery, because it's so demanding, as a kind of developmental node. If you can do cardiac surgery, you can do a very wide range of other things. And so use it as a growth node, as a forcing driver of medical innovation, because the procedure in the West is now so well established, so routine. It has a mortality rate in good hospitals which approaches zero. And in practice, we ought to be able to diffuse this. And so what would be the way of building a system which is not, and this goes back to questions we've asked again and again on the pod about development globally, is how do you diffuse technological capacity into societies which have the potential and have the need, but aren't currently able to put the pieces together? And the optimistic view of this sort of movement for global cardiac surgery is to say, use this as the lead elephant. Right? If you can build a hospital capable of doing this, it will have a diffuse effect on all of the systems around it, because the goal is so clear, the standard is so clear. In India, in China, in the West, we can do this. So what is it going to take to make this possible in a Tanzania? What's it going to take to make this possible in a Ghana? What are the pieces of the chain that we need? And it's, as it were, at the other end of the spectrum from the effort to diversify vaccine production, but it belongs in the same mindset of saying we should be able to do everything everywhere. And if we can't, what will it take to actually move the envelope here? So it's a sort of technology-centered story rather than one that says, well, you just don't have enough money. It breaks that down and says, well, if we had the money, what is it we would need to be able to do basic cardiac surgery everywhere in the world? So I found it a inspiring thing to think about in that way.
Well, yeah, I mean, inequalities aside, I'm glad you have the access you do, Adam. We should probably end this conversation here for now. A reminder to listeners, we do have new episodes in the weeks ahead on heterodox economists. That'll make for some interesting material, I think. But yeah, in the meantime, I think I speak for all our listeners when I say we wish you a speedy recovery, Adam. I'm sitting here in Berlin, and most of my colleagues are in the US, but I realized as I was getting on the podcast today that I speak to you more than anyone else, I think, during the week, just in preparing and actually doing this podcast. So I will miss you too in the coming weeks, but we'll be back in January. So yeah, speedy recovery, and talk soon.
I look forward to it, and I wish everyone well for the holiday season.
Ones and Tooze is written and edited by me, Cameron Abadi, along with Adam Tooze. It's produced by Claudia Tatey, Laura Rossbrow-Tellem, Rob Sachs, and Dan Efron. This show is made possible through the support of Foreign Policy readers. If you're interested in news and analysis from around the world, consider subscribing. Listeners to Ones and Tooze even get a 15% discount. Just go to foreignpolicy.com/subscribe and use the promo code TOOZE at checkout. That's TOOZE. And listeners, as always, we love getting your feedback. You can leave voice messages on the Ones and Tooze homepage on foreignpolicy.com, or email us, podcast@foreignpolicy.com, or you can tweet us. That's @OnesandTwozePod. Thanks very much for listening, and we'll be back in your feed next week.